All right. So up until now, we've talked about we've covered a lot of topics. We've talked at nauseum about different disorders and that affect the brain. We learned how the brain works, how sensations create perceptions, and those perceptions we act on, or develop other thoughts or processes or something like that, right? And then we even got into how personalities are formed over time through behaviors and reinforcements and with our temperaments that help to form those personalities, right? And then we even went even a little further last week and talked about how problems can sometimes occur, especially with our mood or with our personality, or even something neurological or biological within the chemicals of our brain, can create what we know as psychological disorders, right? So with that, we have specialists that somebody with mental health or psychological or psychiatric disorders might have that they can come and see. And a lot of times that's some kind of therapy, right? It could be talk therapy. It could be in talk therapy, we have different types of talk therapy. Some might be psychodynamic, psychoanalytic, all those theories that we learned about. Humanistic is one of them, client-centered, CBT, cognitive behavioral therapy, which we'll talk about later in this chapter. So anyway, you have your options. Some people might benefit from medications, right? There might be a reason for somebody to take medication. So what I always look at is medical necessity in my practice. So if I'm counseling somebody and they seem to be getting worse, right? No matter, we don't really have a handle on things. Maybe their anxiety is off the charts. They can't function anymore. They're irritable at work and they're in danger of losing their job, or their relationship or their quality of life is somehow going to be affected. We would probably look at biomedical or pharmaceuticals, right? Psychotropic medication to help alleviate whatever that those symptoms are that are likely going to cause that person to affect the functioning of their lives. So those are things that we look at as far as medications. And in my philosophy, when I'm in practice, I hope for medications being a temporary basis. We have this thing in our practice that we call pills are not skills. And that just means that with psychology, there's usually a way that we can help somebody overcome whatever ailments, whatever features of psychological disorders that they have by training, like some kind of education or practice in meditation or practice in calming or reframing or whatever that might be, helping that person with those skills so that they don't need to be reliant or dependent on pharmaceuticals. Okay, but sometimes that's unavoidable, and there are certain cases like schizophrenia, for example, is one of those cases that normally somebody with schizophrenia is usually on pills, on medication for the rest of their lives, or for at least a good portion of it. Some people, similarly, with borderline personality disorder or bipolar disorder, might require pills to manage those neurotransmitter and chemicals within their brain, so that they don't get those extreme highs or those extreme lows, right? Or those codependent behaviors, right? So anyway, that's just kind of a little bit of a preview into what we're going to be talking about. So I'm going to share my screen so we can get to it. So I know we haven't done this in a while, but I'd like to start off with our true or false, our fact or falsehood. So if you want to read along here and answer as you can. So first one is, most people who suffer psychological problems become worse without therapy. What do you think? Is that true or is that false?
True.
Okay. Anybody else?
I think it's true.
You think it's true? Okay.
Yes.
Okay. Let me looking for my participants window and I can't find it. There it is. Okay. Yeah. Sometimes I can see thumbs up and thumbs down. There it is. Okay. Based on what I can view on here. All right. So actually that answer is false. All right. Why do you think? Anybody can take a guess as to why most people who suffer psychological problems become worse without therapy?
Probably because they don't notice that they have a problem.
Okay, maybe. Okay. Any other ideas?
Why they don't get worse, or why we think they get worse?
Why they don't, why would that be false? Most people who suffer psychological problems become worse without therapy. Why do you think that would be false?
Could it be like it's something that they've always lived with, and their problems, their psychological problems are not advancing, so like it stays the same? I don't know.
Could be. No, you're on the right track here. Yeah, and that could be a potential reason, is that maybe they've lived with it so long, they just learned how to deal with maybe depressed mood or anxiety or ADHD or whatever it is. So absolutely, that would be a reason for that. We are all pre-built to do one thing, and that's to live, and that's to survive. And we figure out ways to overcome pain, whether it's physical pain or emotional pain. We're pre-wired to figure that out. Okay. Now, sometimes we get stuck. So somebody with depression might, I mean, there's a good chance that they're just going to come out of it. Usually it's event driven normally. Okay. Not always the case. Sometimes it's a chemical imbalance, or it might be an imbalance in vitamins, or something in their diet, or something in their blood, or, secondary to a medical condition or virus. It could be many things, but if it's usually event driven, like the loss of a loved one or loss of a job or something like that, normally people just get over that over time. So they may endure features of anxiety or features of depression, but eventually they naturally get over that. Okay. So it doesn't go without saying that most people, it would be false to say most people who suffer psychological problems become worse. We could probably tailor that to say some people who suffer psychological problems might become worse, but it's not given. It's not saying just because you're feeling blue and feeling down means that you need to have therapy, right? And sometimes we get that wrong. Sometimes we force people into therapy when they really don't want to be there, nor are they going to benefit from that, because not all people do. Some people do, a lot of people do, but not everybody, especially if it's temporary and something they can overcome on their own. And so we'll talk about that here in a little bit as well. One can experience beneficial consequences from therapeutic treatment by simply believing it will be effective. What do you think?
True.
Okay. Anybody else think it's true? Okay. Absolutely. We call this the placebo effect. Okay. And I don't know, does anybody know anything about the placebo effect? I think your book covered it. I don't know if we talked about it in class. What is the placebo effect?
It is not when you think something, like, for example, if you drink juice thinking is alcohol, you will feel like you are drunk. It's not that.
Okay. Yeah. Very similar. That's an example of a placebo effect. So placebo in its definition is a sugar pill. And back in, I think, in the 1950s and 1960s, they were researching the effects of, I think it was stress or headaches or migraines. I think it was migraines. But they offered two groups of people. They told them all that they were getting medicine to help with their ailments. And they gave two groups. One of them, they gave an actual medication, and the other, they gave a sugar pill. And what they found is the people that they gave the sugar pill, their ailments went away. Not all of them, but a good majority of them, to the point where they notice, hey, we're onto something here. So the psychological effects of being in therapy alone are enough to be of benefit. So maybe it's just having that extra eyes or extra ears, or somebody to fall back on if you need it, that comforts somebody and helps them through that process, whatever process they're going through. So anyway, yeah, placebo effect would be at force there. All right, next one. The various therapies are so different that it is impossible to find any commonalities. What do you think?
False.
False. Okay. Okay, seeing a lot of falses in the participants. Okay, absolutely, that is false. There are some commonalities between, no matter which one you go through, whether it's psychodynamic, psychoanalytic, CBT, DBT, REBT, EMDR, KFC, CNN, ASAP. I'm just throwing out letters now, but no matter what those are, there's a common root in that the person is being validated, the person is being listened to. So those are some commonalities, and there are other commonalities between the other techniques that are used in there, but for the most part, yeah, that is false. Okay. The training and experience of a therapist are crucial factors in determining therapeutic success. What do you think?
True.
Okay. True. Seeing a false in there. Okay. That is actually true. Okay. So good job with that one. So the training, not only the training and experience of the therapist, but also the relationship, the ability to form a relationship with that person, with that the individual that's coming in for therapy. Because I've seen that happen. I've seen some remarkably brilliant therapists. I mean, top of their class. They know just about every treatment model that's out there, or everything in depth with their treatment model that they use, but they just can't connect with the person, right? So that's an important thing. If they have a strange disposition, or maybe they come off as cocky or something like that, right? That would be the Shamika, you put, remember what about Bob, right? Absolutely. Yeah, that wasn't a very good relationship between them, right? We saw Bob become codependent, and the therapist was not very, he was kind of arrogant. He was egotistical, right? And I would say probably some narcissistic features there. So it was all about.
I would say that he has never have an experience with someone like Bob, nor has he been trained like how to, probably he has been trained, but the experience part of it.
I would say absolutely. But also with what I can't remember Richard Dreyfuss's character's name in there. But what I mean, the therapist was he more concerned about his patients, or was he more concerned about his own fame?
Definitely his fame.
Right. So he was on this power trip, and he had somebody that needed him, and he wasn't addressing those needs, which made Bob want to need him more, right? So that's an example. He was a brilliant therapist, but he had some personal things that he was working through that were inhibiting him to be an effective therapist in that moment. So we may see that. So therapists are people too, right? So they're held at a higher standard, but sometimes life happens with therapists, and sometimes that might affect their therapeutic relationship. Okay, a common ingredient underlying the success of psychotherapies is the client's expectation that psychotherapy will make things better. Okay, and I think we've already covered that, so that is obviously true. Okay, so let's talk about types of therapy. On the left-hand side here, we've got psychotherapy, which is basically what we talk about psychological issues going on in that person's lives, right? Treatment of emotional, behavioral, and interpersonal problems through the use of basically just psychological talk. Okay, and it's really there to encourage the person's understanding of the problems, and also allow them to build up on their communication skills as to what exactly is going on. And then aside from that, along with that, we also have biomedical therapy, which we talked about, use of psychotropic medications or other treatments to relieve symptoms associated with psychological disorders. So what are some things that we might use biomedical therapy for, do you think?
Adderall?
That's one that we would use. Yeah, absolutely. But what are some symptoms that we would hope to alleviate with psychotropic medications? Anxiety, yeah, right. And we talked about that earlier. If somebody is having a hard time sleeping or having a hard time focusing, how about sleep? What do you think? Is medication good for sleep?
Yes.
Okay.
I would say yes and no.
Okay, yes and no. Why?
I say yes, because it can help you. Like you can take it, but I always say no, because then you rely or depend on that medicine.
Yeah.
And then when you take it, um, with time, is you need to take more doses of that same medication because your
Yep.
body feels like, oh, it's normal. So now it won't do anything. With time, it won't do anything. So you will keep like taking more and more and more and more until it becomes a problem.
Yeah, yeah, absolutely. And they're both and we look at two factors with sleep medications is that they are habit forming, which means we get in the habit of taking them. And if we include that in our sleep hygiene every night, then once we don't have that, we've become not only chemically dependent, but it's become part of our routine that is no longer there, and that could affect your sleep. So yeah, the best way to help somebody with sleep is to teach relaxation techniques or figure out diet. You know, diet could be a big part of that. I had a client that was having a difficult time sleeping. She got off work about 10 o'clock and tried to get to bed at 12 so she could be up around 8, 9 o'clock to take care of her kids. So she was working the second shift. But she was waking up, you know, unexpectedly around 3, 4, 5 o'clock in the morning and not getting a full night's sleep. So what we found, and I love, you know, we did our sleep journal, right, earlier in the semester, and this is what one of the effective uses of that is using a sleep journal. I was able to document her activity from the time that she got home to the time that she went to bed, and even throughout her day, and found two things. She was having coffee up until about 9, 10 o'clock at night, and she came home and ate a full meal, which was not good for her digestive system. So anyway, that really had nothing to do with anxiety. She didn't have anything going on in life except the sleep issue was causing anxiety. So the anxiety was secondary to her insomnia. So anyway, it's simple stuff like that sometimes, and sometimes it can get a little bit more complicated or a lot more complicated, but you know, just working with people and figuring out, you know, what is your routine, what can we do a little bit differently. So anyway, yeah, so biomedical therapy with sleep is sometimes effective, especially if you don't know what's happening and there might be negative consequences for students or for people not sleeping. I was thinking students because same thing, you know, we get this time of year, I get a lot of students that said they're not sleeping because they're up late and doing papers and studying for exams. And in those moments, do you think sleep medication would be appropriate? What do you think? Like during finals week or the last couple weeks of the semester?
I will say with a properly scheduled, yes.
Okay. I would look at more relaxation techniques because again, this is a temporary stress and it's not long term and it would be expected. I'm not sleeping that well because I'm up late at night grading your papers. But you know, the introduction of psychotropic medications, again, I would worry about that inducing something into a habit that I don't want. So yeah, I would probably advise against taking medication just for temporary relief. All right, so why is therapy important? Because we talked about that. Not everybody is going to get worse with therapy or without the use of therapy. So, but oftentimes people get stuck. They don't know how to negotiate a problem. They don't know how to move through whatever stress it is that they have in their lives, and they just need that extra boost, and maybe that extra set of ears and eyes to help look through their life and see where maybe some indicators are, where problems are, right? And helping them to work through that. So psychological disorders have an enormous social, financial, and personal costs, right? It could affect somebody's work. It could affect somebody's relationship. It could affect how they're driving, the safety of them, especially if they're over anxious and they can't get sleep that night and they have a long drive the next day. So there are many, many implications to that. And also medically, right? Why medically? Why would anxiety or depression have medical costs to that, do you think? What kind of medical problems can come from psychological disorders? I think we talked about it in previous lessons.
Can you repeat the question?
What kind of medical conditions or problems can arise from psychological disorders?
I don't know why I'm stuck on this one.
I have an idea, but I don't know how to express it.
Okay.
For example, let's say that you are in a bad family and you are depressed, you have anxiety, or you have a psychological disorder that you need help from other people to feel comfortable. For example, with the family that is ignorant and probably you are depressed and you need help, if they don't help you with that, but you probably will end up doing things that people don't want you to do, like probably suicide and all that stuff.
Yeah, the ultimate medical condition there, right? The ultimate negative outcome in the medical and psychological profession is, suicide. Absolutely. And you kind of touched upon a really important part there, is that people with early psychological disorders and maybe a bad environment to grow up in, they continue those bad habits over and over and over until they become adults and have families of their own and perpetuate those bad habits into future generations, right? So that could be a risk factor. Off the top of my head, looking at PTSD in children, right? We do know that children that encounter that endure PTSD or some kind of traumatic or ongoing stressful event tend to have their sleep affected, tend to have higher anxiety about life and mistrust in their environment, which can also lead to lack of growth hormones, right? We talked about that when we were discussing consciousness. So lack of growth hormones could stunt their growth. It could affect their ability to repair their bodies, right? So we looked at all sorts of studies that indicate that people with high stress or high anxiety or perceived stress usually have other medical problems such as high blood pressure, high heart rate, or irregular heart rate, or some kind of heart conditions. They may not heal nearly as fast, right? So we can show that. Cortisol released in the blood system takes away from the immune system and the ability for the body to repair itself. So those could be implications to high stress. So anyway, those are just some examples. Diabetes has been linked to psychological disorders as well. Doesn't mean people with diabetes have psychological disorders. It just means that psychological disorders could lead to that. Okay. All right. Treatment can help reduce some of these costs and provide a better quality of life to the person suffering with psychological disorders. So what are some obstacles to therapy? What are some reasons that that people don't seek therapy or don't stay in therapy? What do you think?
Mindsets.
What do you mean by mindsets?
Some people struggle to accept that they need help.
Okay.
And probably the way they grew up and their environment make them think that they don't need help. It's just part of their life,
Okay. Yeah, absolutely. So your environment, a person's family might be an obstacle to that, right? They might not have the support at home for somebody to stay or engage in therapy. They might put them down or be judgmental in some way, right? We see that a lot. It's ridiculous how many people that come to my sessions and tell me that they don't want their family finding out about it because they're worried about being ridiculed or judged in some way, right? So that could happen. How about gender? What do you think? Are men most likely or less likely to go to therapy over women? Not over women, but compared to women.
Less likely.
I would say less likely.
Why is that?
Women are quicker to ask for help
Mm-hmm.
than men.
Absolutely. Yeah. Yeah. Is that something that's ingrained in our culture, in our beliefs?
Yes.
What are boys taught when they're young? Are they taught that crying is okay?
No, you're supposed to be like the bigger like person. Like you're supposed to like always be there to help other people. Especially
Right.
like yeah, like over time, like men were always like taught that they're supposed to like be there for like women usually and make sure that they're like a helping hand.
Right. We're told at a young age, men are told and boys are told at a young age, stuff that down. Don't talk about stuff, don't cry. Even to the point where, I've heard some parents unfortunately tell their kids, I'll give you something to cry about, right? So boys are not really in traditional families for the most part, like especially back in the 50s and 60s. This is a product of a generation that went through multiple wars. They're taught that the boys, in order to be defenders of their country, that they have to be rough and tough and they have to stuff down those emotions. So there are many probably sociological reasons as to why that occurred, but we do know that it has continued, and we do see that in today's culture, not nearly as bad as it was, but it still exists. So yeah, I mean, very much so. Boys are taught don't cry, girls are taught it's okay to cry, right? So with that, we just see this trajectory. Chris brought up a little earlier that that these patterns go through life. Well, if you're taught that it's not okay to express your emotions, how do you think that person's going to be when they become an adult? Are they going to be likely to express their emotions? Or are they going to stuff it down and hold it in? So that trickles down into asking for help. And when we see somebody that needs therapy and they get stuck in that pattern, they're less likely to go because they don't want to show those emotions, right? They don't want to talk about it. Some other obstacles might involve like financial issues. Like somebody may not have coverage to go to therapy. Therapy can be expensive. I think on average, I would say a therapist costs anywhere from about $200 to $350 an hour, right? How many of you can afford $200 to $350 an hour? $350 an hour for a really, really good, really well-educated and therapist. That's quite expensive, right? How many of you would pay for that, do you think, out of your pocket?
If I had the money, I would go to therapy, to be honest.
What's that?
If I had the money,
Yeah, if you had the money.
I will spend all the money that I can on therapy, to be honest.
Okay, yeah. If you had the money, but some people don't. So we depend on the healthcare system to provide that for us. Not everybody has a full-time job with health benefits, right? It could be that maybe they're in an area that doesn't have well-educated or well-reputation therapy, right? All right. People may not realize that they need treatment. Okay. Again, that pride issue. They may be of the mind that they're in some kind of denial. I can't be depressed. That doesn't happen to me. I can't have an addiction. That doesn't happen to me. That pride issue might get in the way of their ability to seek out and be successful in treatment, and may not be able to afford it, like I said. And they feel that seeking treatment is a sign of weakness. So when I'm in my sessions with, especially when they just start out, one of the things I praise the person and let them know how proud I am that they came and did that, because that's really a big step for some people, is to overcome that pride and just admit that we need help of some kind, no matter what kind of help it is: financial help, spiritual help, psychological help, even medical help. Medical is a little bit different because the pain doesn't stop until we go to see somebody, right? With psychology, it's kind of the same principle, right? If you have an emotional pain that is so great, you go see a doctor. You want to go see somebody that can help you with that. Otherwise, that pain continues and it worsens, and it could start affecting other things, right? Similar to medical. So successful treatment may be hindered by poor professional training as well. So for the most part, a lot of states have criteria that the individual has to meet. They have to have educational standards that they have to meet, go to certain schools and prove that they've gone through classes and that they can be an effective counselor. So the word therapist and the word psychologist are very safely guarded, and it would be illegal for somebody to come and profess or say advertise themselves as a therapist or a psychologist when they don't meet certain criteria, as that could be dangerous. Can you imagine if anybody just decided, hey, I'm gonna advertise myself as a psychologist, and you go and it would be similar to, maybe you really like, I don't know, Doritos, right? And the store somehow markets this lesser brand of Doritos, and you pay the expensive price for having those Doritos, but yet you find out that they're, I don't know what the great value brand or something like that, right? You're not getting the quality that you paid for, which is a little bit different with Doritos because that's just a personal preference. But when we're talking about your mental health, that could have significant impact on that person's life and the lives of the person around them, right? So if you have somebody that's unqualified to do that, they could actually do worse if they don't have the credentials. All right. So what are some types of therapists that you can go to? Okay, our lecture today, we're going to cover 4 types of them. Right, we have the psychologist, we have the psychiatrist, we have a social worker, and we have a counselor. Okay, with the psychologist, it's somebody that has a degree in clinical or counseling, clinical psychology or counseling. And they usually hold a doctorate. Not always. Some states they allow a master's level to have a license as a psychologist, but they usually hold a doctorate, and they're trained in psychological testing, evaluation, and diagnosing people with disorders, as well as psychotherapy. And they have the ability and the training to do research, which also helps to prevent mental and emotional disorders by using the most effective type of therapies out there, right? Usually psychologists stay pretty well integrated with the psychological community. They go to conferences, and there's a lot of education and continual education that happens after they get their degree, okay? Whereas, so a psychiatrist is significantly different. So a psychiatrist has a medical degree. And I think we talked about this early in the semester, but we're just kind of recapping as we get into different types of therapy that a person can get into. So they hold a medical degree. So a majority of their time is spent in medical school. However, they're given about 1.5 to 2 years of classes and training to help with the treatment and diagnosis and prevention of mental health and emotional disorders. So they have all the authorities to prescribe medications and other medical procedures. And usually they oversee those medical procedures as a psychiatrist. The difference between the two of them, you might think, well, why don't I just go to psychiatrist? Problem being is that a psychiatrist usually doesn't have the training to go with talk therapy, to sit with somebody and talk to them for about an hour. Usually that's what their therapeutic processes are. They don't have the expertise to work in groups, okay? They're really medical. A lot of their expertise is in the medical field and psychotropic medication, pharmacology. That doesn't mean that there aren't psychiatrists that don't talk to you. They just don't have the well-rounded training that a psychologist has to do that, okay? So that's really the difference. A psychiatrist you would go to for more severe, more acute disorders that they could prescribe medication. A psychologist, and usually they follow that up with a therapist or a psychologist or a counselor so that they can get that talk therapy as well, okay? Then you have a social worker. So social workers focus on assisting people in difficult situations such as poverty, family conflict, abuse, homelessness. Usually social workers have a master's level education, and they are really instrumental in pointing people in the direction of services that they might need. So we do see an increasing number of social workers providing counseling services. And I'm not really here to advocate either way. If there is a need in the community for some kind of mental health usually just talking to a social worker is helpful. I'm not, they may not be as qualified as a psychologist, or they may not have the experience as a mental health counselor, but at least it's something in that community, right? So they are there, and they are very resourceful as far as connecting people with any kind of services or funding or something that they might need to improve their quality of life and help them achieve whatever goals that they're aiming to achieve. Okay. And then lastly, we have a counselor. And a professional counselor usually holds a master's degree in counseling. In drug counseling, we might see that a little less. We might see somebody with a bachelor's degree providing some kind of counseling service for drug and alcohol counseling or substance abuse addiction. But normally we see a counselor at a master's level in counseling, and they usually have expertise similar to a psychologist with assessment, counseling, therapy techniques, and they're more likely than other disciplines to give attention to the client's spiritual and educational and professional well-being. So meaning that a psychologist you're going to go to if you have like if you have an acute depression, features of depression or features of anxiety or something that is psychologically based. But a counselor is going to be much more well-rounded, and they're going to be able to help somebody out with like even pointing them in spiritual directions or education or something like that. So those are really the four types. Any questions on those before we move on? Okay. All right. So let's dig back a little bit in history as to how the treatment of mental health disorders occurred early in history. So the early treatment of mental health disorders was really marked by superstition and techniques that today we really consider barbaric or brutal, right? So oftentimes people with psychological disorders, there wasn't really much of a treatment. They were more confined, and they were put into sanitariums and asylums and places that they couldn't harm other people, and in some cases they couldn't harm themselves. So it was more of just a way to store them. Okay. Prior to that, people were regarded as heretics or regarded as possessed or something like that. So anyway, so the main goal was protection of the public away from people that encountered those mental health disorders. So early methods of treatment included fanciful contraptions and cures without much basis in science, such as transorbital lobotomies. Maybe you've heard of those. Lobotomies is where they scrape out the forefront of your brain, the prefrontal cortex, which is responsible for emotional regulation and upper level executive functioning. So all of your high thinking and emotional regulation is done in your prefrontal cortex, right? Your command and control center for the rest of your brain. It's what separates us from our primate ancestors, right? So our primate cousins, I should say, depending on your point of view. But chimpanzees and apes, they all have brains similar to ours, but they don't have a well-developed prefrontal cortex. So one of the theories was, well, if we remove the person's ability to feel things, then maybe we can alleviate those negative features of whatever psychological disorders they're experiencing. Great theory, right? But as we were talking about in social psychology, confirmation bias, right? We do something that leads to some kind of success, even though it's not the best outcome. So as you can imagine, scraping the front of somebody's brain through their eyeball, probably not an effective in the long run, because we're going to encounter other cognitive disabilities. And strangely enough, I live down here in West Virginia, and I'm about an hour away from what they call the Trans-Allegheny Lunatic Asylum. That's the name of it. If you ever get a chance, look it up. It's actually really, really cool. It's shut down now. I think it's shut down back in the 90s. But as of like the late 70s and the 80s, they were still doing this. They were still performing transorbital lobotomies. And in fact, they had a psychiatrist that was performing them up to 200 a week. for some of these patients, and eventually they caught on to what he was doing, and they stripped him of his license. I don't know if he ever went to jail or anything, but they found out that that his methods were cruel and brutal and really less effective in the long run, and a lot of people were dying because of it. So yeah, I mean, it's just fascinating to hear that even in my lifetime, this kind of brutality was going on, and it was endorsed, right? It was condoned. So advocates such as Dorothy Dix and Felipe Pinel that spurred reform of treatment of the mentally ill. So Dorothy Dix, known as Nellie Bly, many of you probably heard of, she infiltrated the some of these insane asylums, as they were called back in the day, to just see what the living conditions were like. And what she found is she was able to get admitted, and then found that there was more of an interest in keeping her there than what was actually occurring. So they diagnosed her, I think it was with histrionic or hysteria or something like that. And she was committed to an institute that they wouldn't let her go, even though she was not displaying any kind of symptoms whatsoever. So anyway, she wrote a book back on the treatment of mentally ill, and really highlighted a lot of atrocities that were occurring in these storage facilities for people with disorders, right? So I've got a video here to play for you.
During the first half of this century, mental hospitals tried to use medical treatments for people with severe mental disorders. However, the medical procedures used were crude, largely ineffective, and often unintentionally cruel. Some of the leading approaches are shown in this segment. A popular technique was hydrotherapy, in which patients were sprayed by water in order to stimulate them. The wet pack consisted of packing, that is, wrapping, patients in wet sheets. This next procedure, the continuous bath, was kept at 98 degrees Fahrenheit. Its aim was to sedate patients. Hot boxes and lamps were used in order to help relax patients. A predecessor to electroconvulsive therapy was insulin therapy, although this approach was more dangerous and less effective than ECT has since become. Insulin therapy was developed by Viennese physician Manfred Sackel. It was used primarily on patients with schizophrenia. The idea was to give patients insulin, which would make their blood sugar drop. The patient would then slip into a coma, and most importantly, would experience a convulsive reaction. One form of reaction brought about by insulin therapy was called wet shock because it included profuse sweating and drooling, as seen here.
And by the way,
another reaction brought on by insulin therapy was so-called dry shock, involving a full brain seizure.
We don't use any of these techniques anymore, obviously, for obvious reasons. What do you think? Does this look cruel?
Glucose, given by nasal tube or by injection, was needed to bring patients out of their insulin-induced coma. Metrazole therapy, an intravenous injection of metrazole on patients, again primarily with schizophrenia, was another form of convulsive therapy that was used prior to ECT or electroconvulsive therapy. It was developed by Hungarian physician Vanislav Meduna, and the intravenous injection of metrazole typically produced grand mal type seizure. Finally, one of the most notorious of all early procedures was the lobotomy, a brain operation in which a surgeon would cut the connections between the cortex of the brain's frontal lobes and the lower centers of the brain.
Yeah, good question, Chris. Whose idea was it that that these were good ideas, right? Again, we look at the success, right? The goal of these treatments was to prevent the person from being a danger to themselves or being a danger to other people, regardless of what that meant for long-term treatment. So yeah, they were just trying to remedy something, and that was the thinking at the time. And probably ways that we're dealing with, because we still use ECT or electroconvulsive therapy. That's still very much used, and it tends to be effective in treatment of certain illnesses. So yeah, we still use these, and who's to say, 20, 30 years down the road, our children and grandchildren are going to be looking back and thinking how barbaric and cruel we were with some of our treatment methods, right? I'm reminded of like Star Trek, where they just wave the little tricorder over somebody's body and it heals whatever it is it needs to heal. I think we're probably not there yet, but once we get there, we're going to see our operations, our medical procedures as being barbaric and cruel. So anyway, it's all about perspective. But at the time, that was cutting edge technology. That was cutting edge treatment. And one that as of like 40 years ago in my day was still being used. All right. So psychotherapy effectiveness. So those were some medical procedures that occurred. Now we're going to kind of shift gears, because we learned that talking things through and being able to, in most cases, in most mental illnesses and psychological disorders, we're able to talk people through in reframing or altering their behaviors in a way that it doesn't impact them, or stopping and think, using that prefrontal cortex as opposed to disconnecting it. Because we disconnect it, we act like our primate cousins. Yeah. So the effectiveness with psychotherapy, both the clients and clinicians report higher rates of effective treatment, but these reports are usually subject to and prone to bias, right? Especially if it's coming from the therapist themselves, right? So outcome-based research, however, has consistently found that psychotherapy is significantly more effective than receiving no treatment at all, even if the person just believes that therapy is helping them. That could be efficacious alone. So therapy is most effective when the problem is clear-cut and specific. However, when it gets complex and convoluted, like if we have somebody that has compounding issues stemming from some kind of childhood trauma and juvenile delinquency and oppositional defiance disorder, and out of that comes some other major illnesses such as ADHD. So we can if we track the pathology of somebody that gets really, really complicated, there's a lot of unpacking to do there. There's a lot of work that we would have to go through. So it might not just be as effective as talking somebody through their current world situation. They may have some stuff that therapist may not be equipped to handle. And we do, in those cases, we see people with long history of various mental health illnesses, usually doctor shopping. They're going around from therapist to therapist, either out of necessity or because they get some kind of effectiveness out of it until they don't. Okay. So factors that contribute to effective psychotherapy are the quality of the therapeutic relationship. That's what I meant, I talked about before, is regardless of how educated that the therapist is or how willing the client is, there has to be a therapeutic relationship. There has to be that trust, that ability to be vulnerable with the therapist. Because if that doesn't occur, they might not be able to show some kind of caring, or they won't feel like they're being empathized with, and the response of the therapist could be seriously degraded. Okay, so motivated and optimistic client, that's important too. So there are two types of clients that I've seen in my practice. One that comes to me because they want to, and one comes to me because they have to. Why would somebody have to come to therapy? What are reasons that somebody might be forced to go to therapy, and who forces them? What do you think?
Maybe like a court order.
Yeah, that's probably the biggest one. Court order, usually anger management, like some kind of domestic violence or aggression or violence towards another person, or even drug or substance use, right? Or DUIs even. In those cases, oftentimes a court forces a person to go to therapy. I've seen instances where a spouse or significant other force or coerce, or I don't want to say force, but coerce the person to go to therapy. Otherwise, it might mean the end of their relationship. So those are reasons why somebody might go to therapy. Not in all cases. In fact, alarmingly, especially with substance use, it's not very effective. Okay, because the person may not be engaged, they may not be motivated to better themselves, they may not even admit that they have a problem. They just see me as a therapist as an extension of the legal system, or an extension of their significant other that's forcing them there in that situation. In those cases, that therapeutic relationship usually doesn't form, and it's oftentimes unsuccessful. And it's also important to have a culturally sensitive therapist, right? And I think we talked about that in previous classes and previous lectures, because if I have to be aware of a person's cultural background. Like, for example, if a woman who's Muslim comes into my office and wants to talk about issues at home, about her husband being emotionally abusive or something like that. Normally, under conditions, we would explore options as to what it would look like to separate from that family, right? To separate from that relationship in Western cultures. But in Middle Eastern cultures, do you think that would be an effective goal to work towards? And why not? Answer is no, but why not? Why wouldn't it be effective to help that person if their goal is to get out of that relationship? Why would that not be effective?
Because of their culture.
It could have. Go ahead.
If I'm not wrong, Muslim women are supposed to be home takers or something like that. So they can't work or do stuff like this. So it's more difficult for Muslim women to get out of those kind of relationships or situations, because since they are born, their life are kind of made. I don't know how to explain it.
No, you're on the right track there. So yeah, their culture, their role in their culture is really determined by the culture itself, right? So that person would have to have the goal of leaving that culture if she were, I'm going to say she, if she were interested in leaving that marriage, because that is something that might not be acceptable to her immediate support. So that could isolate her, and that could have her ostracized from that, ousted from that group, from that cult, from her community, which may precipitate more severe or longer term issues for that person. So anyway, just being culturally aware of that is really, really important. Knowing where the clients come from and making sure that the therapists are sensitive to those factors, right? So there is relative effectiveness in different psychotherapies, right? In general, there is really little or no difference in effectiveness of different psychotherapy. So what that's saying is no matter what kind of psychotherapy a person gets into, it's likely to be effective, regardless of whether they're using CBT or RBT, REBT or DBT or the client-centered talk therapy or whatever it is. We do show that any kind of therapy would be more, any kind of therapy would have its effectiveness in some way. However, depending on the issue, we might want to consider different types of therapy, especially if it's very specific. And there are some things there's some list below that shows that highlights that. So for example, type of treatment for that we would look to see if cognitive behavioral therapy works is like panic disorders without agoraphobia, right? Because agoraphobia is afraid of open spaces, afraid of having panic disorder in open spaces, right? So wouldn't necessarily be effective in that because the person's not going out. Does that make sense? If the person doesn't leave their house, then they can't go to therapy oftentimes. Or, since COVID, we've seen the advent of using teletherapy. So, that would be a caveat to that. Cognitive therapy, just is reframing how we think, how we view problems, which is helpful with depression and bulimia, right? Interpersonal therapy, looking at how a person connects with other people or reaches out for support would be helpful with depression. Behavioral therapy exposure from response prevention would help with OCD, obsessive compulsive disorder, and also childhood bedwetting and marital difficulties, right? So different types of therapies are proven to be more effective, like EMDR, eye movement desensitization, EMDR, and reprocessing, which is using some kind of either clickers in a person's hand or a light bar that activates both sides of the brain as you're talking about some like a past trauma or something. So very effective with PTSD. However, EMDR hasn't really shown any kind of efficacy for things like bulimia or anorexia or even depression for that matter. So some biomedical therapies and effectiveness of those. There are several types of psychotropic drugs that have proven useful in the treatment of various psychological disorders. However, the actual effectiveness of many drugs, especially antidepressants, is debated by psychologists and others. Again, looking at the placebo effect, because people taking the drugs alone might actually cure themselves, right? So it doesn't matter what you gave them. They might actually be processing with the expectation that they're doing better. So we could see that. So the decision to use medication, it's complicated, because we have side effects such as dry mouth, weight gain. There are some medical conditions that can emerge because of these medications, and even long-term use of these medications, such as lithium, for example, can cause tardive dyskinesia. Many of you have probably seen that on recent ads, when somebody is shaking or they're lip smacking, they're smacking their lips a lot and not talking. So anyway, those are some side effects to either long-term drugs or overuse of those drugs. But so we always have to consider what is the benefit of the medication. Okay, so again, we know that, for example, sleeping medication is habit forming and chemically dependent. It could cause a chemical dependence in a person. So we want to use that sparingly, because if they do get hooked on that drug, we have to have some kind of an exit strategy. Otherwise, they're just going to require more and more of that psychotropic medication to help them sleep, which is not an intended effect of that. We don't want that to happen. So anyway, yeah. So we talked about the placebo effect. Again, the effectiveness of just having the medication alone. I'm not going to really go through that again, since we talked about it. But this just kind of shows that people that took Prozac and people that took placebo, they've done many studies on this, and they show that the effectiveness and the reduction of obsessive compulsive disorder since the beginning of the study had significantly dropped just based on the people thinking that they were receiving medication. Okay. So comparing psychological and biomedical therapies, several, excuse me, several large-scale studies suggest comparable effectiveness between psychotherapy and biomedical therapies. And I always look at it, and if I can use as an analogy, when I see somebody in a therapeutic capacity, I look for what I call the recording light. Maybe many of you have your iPhones, right, or your smartphones, and when you hit a button on there, you have the recording light that's going, right? That tells you what? That tells you that your iPhone is doing something, that it's learning, that it's absorbing information, it's recording all the things that a person's saying or doing, or an event that's occurring, right, that you want to replay. So what I look for in that individual is, are they getting what we're talking about? Are they making changes? Are we seeing some kind of progress in therapy? Or is anxiety or depression so high, or whatever it is, like manic states during bipolar events, are they so high that we're not seeing any progress, or even worse, we're seeing a regression? We're seeing negative impact, that things getting worse for that person. If that's occurring, that might be a time to consider psychotropic medications to stop that situation from getting any worse, so we can kind of see the record light, especially with ADHD, right? I've done extensive work with kiddos that have ADHD, and one of the things I look for is that record light, because we can work on organization skills all day long. We can work on getting into routines all day long, but if the person's not getting it and they're not instituting, they're not relaxed enough to take those skills or learn those skills, then we might have to consider medication just to level them off enough so that they can start putting those things into practice. And then we can look at removing the medications a little bit later. Okay, so clinicians are increasingly combining the two therapies, biomedical and psychological, and supplement use of medication with different kinds of talk therapy, which we are finding helpful. And brain studies indicate that psychotherapeutic and biomedical treatments have a similar effects on brain activities and neural processing. Okay, so what are some dangers of therapy? Let's kind of go through these quickly. So as I said, some psychotropic medications, especially the overuse of benzodiazepines and for anxiety, can lead to dependency. Now, interesting little fact, I shouldn't say fun, this is actually tragic. There are two types of substances that that humans can die from with withdrawal. So, which means you have these substances in your system and then you take them away abruptly. What are those two substances? Does anybody know? Should offer.
Alcohol and benzos.
Absolutely, benzodiazepines, right? So what they do is they activate your dopamine receptors and kick in your serotonin and help the person relax, right? They help regulate their mood and reduce all those sympathetic nervous system sensations that are being activated by the brain, right? So if somebody is taking high levels of benzodiazepines and then all of a sudden they abruptly stop that they usually wind up with tremors, they wind up with vomiting, lack of sleep, irritable mood, and they just bounce all over the place. But they could actually their heart could stop with the abrupt cessation of that. Same way with alcohol. Somebody that uses hard alcohol for a long period of time and then abruptly stops, they may encounter like flu-like symptoms, and eventually their heart would stop and they would stop breathing. And that could happen weeks up to a month after somebody stops drinking. So yeah, it's very important. That's why they have detox centers to help people reduce some of those bad symptoms and keep them safe. So just kind of a note, if you know anybody that is dependent on benzos or alcohol, it's very important to have them seek medical treatment immediately, especially if they're trying to quit, because they could have serious negative impact from that. Some antidepressants have been linked to suicidal thinking. So you see all those disclaimers on TV. If you experience suicidal thoughts after taking this medication, stop the medication and consult your doctor. That's why, because antidepressants might make somebody's conditions worse. We don't know everybody's body is a little bit different. So that's why it's very hard. Psychiatrists struggle with finding the right medications for the right symptoms, because everybody metabolizes medication a little bit differently. And if they over metabolize, it could worsen the condition, and it can worsen the sensations and features of depression, causing suicidal thoughts or thinking, which might cause them to act on that. So let's see. So anyway, it's always important to work with the doctor and let them know what's going on. Misdiagnosis or misguided therapeutic interventions may result in iatrogenic or illness or disorder or symptom that occurs as a result of medical or therapeutic treatment itself. So one thing I always try to do when somebody comes to see me is I try and find any explanation whatsoever. For example, if somebody comes to me and tells me that they're having a hard time sleeping, or they are feeling depressed lately and they don't have a reason why, we might look for medical reasons in conjunction with talk therapy. So maybe having them connect with their doctor so that they can maybe do a full panel blood lab and just see, if there's anything out of whack there, because believe it or not, oftentimes vitamin D and folic acids are big reasons for bouncing of energy levels, right? So misdiagnosis, it would be a disservice for somebody to come in with sleeping issues or depression features, and for me to start treating them with antidepressants without knowing the full story, because the antidepressants may not even work, right? All right, so those are some dangers to therapy, and then just some examples of how therapy is used. Are there any questions? How'd y'all like that? Did that help answer some questions as far as what therapy does, what different types there are?
Yeah.
Now, keep in mind, again, this was just one small chapter. You can actually, for different types of therapy, each type of therapy can be expanded in one or even two classes sometimes. For example, I had to take psychotherapy interventions, and there were two of them. It lasted almost 9 months for me just to go through that, and that just really focused on CBT and CBT and REBT, which is rational emotive behavior therapy. So yeah, I mean, really, you can expand each one of those types of therapy out into entire classes or entire training events. So just keep that in mind. I know we brushed over a lot of it pretty quickly, but if you're interested in that, again, I encourage you, maybe take a class in this and just to see what something that might be of interest to you might be available. Okay. All right. Any questions before we part today? All right. Well, if nothing else, I hope all of you have a wonderful weekend. I will see all of you on Monday. I'll send out an email probably on either tomorrow or Friday, letting you know who's going to be presenting and when. So I'll try and break it up evenly. If we have like 4 presenters, maybe we'll do 2 on Monday and 2 on Wednesday. Or how would you all prefer to do that? Would you like to do them all in one if possible, or break them up in different days?
I'd like to break them up.
Okay. Anybody else? Anybody else have a preference?
Agree with that.
Okay, okay. All right, well, let's see how many we get, and then we'll kind of go from there. But if nothing else, have a great day, have a great weekend, be safe, take care of each other, and we'll see you back here on Monday.